in exams, if by chance some examiner tells you, you write some biopsy report, the terminology of GBM don't use. GBM terminology is only for ultrastructure examination. So whenever you use terminology GBM, that should be restricted only to EM, electron microscope. Otherwise, you see globular capillary loop or globular capillary wall. Okay. So this is a ultrastructure examination EM. This was a PTC which is showing. In PTC, you are going to see PTC multi-layer. Okay, and C4D will be positive. So this is just to highlight. There was one. So I just want to highlight the CG score, chronic globulopathy score. It could be 1. It could be. So you can see here. Just see this capillary loop, which is like thin, and just compare this capillary loop with this capillary loop. You can see some clear space in this capillary loop. You are able to visualize. तो पैथोलॉजिस्ट के पास ना मन की आंखें होती हैं, हमें दिख जाता है, आप लोगों को नहीं दिख रहा है. If you see a clear space in the capillary wall, that is early transplant globulopathy. And when it is at one more thing, you can see segmental sclerosis also in chronic case. Many times, FSGS has become a base basket diagnosis in transplant biopsies. In transplant setting, you can see FSGS due to multiple reasons: chronic AMR, chronic CNI, hypertension, diabetes, and obviously FSCS, primary photocytopathy, recurrent or demo. Okay, so many times, so pathologists, the most easiest lesion to pick up in a kidney biopsy is the FSGS lesion. So we'll say FSGS lesion. What is that FSGS due to? So you have to look at other areas. Just see there is a clearing of the capillary wall. So this and there are inflammatory cells within the globular capillary. So all these features suggest that there is an underlying chronic AMR and secondary FSGS. One more thing, whenever you see a FSGS lesion in a chronic AMR, that chronic AMR is a chronic, very chronic kind of AMR. Don't try to give plasmapheresis in those kind of cases. It is not going to help. Even if IFTA is 10%, it is not going to help, because that means there is a significant glomerulochronicity which is already there. This is just to, here you can see that there is one membrane like this, capillary wall, and there is one capillary wall like this, and inside there is a clear white space. So this shows extensive duplication of the globular capillary wall. In other words, this is also transplant globulopathy. But since I am seeing glomerulitis, I am seeing lot of cells within the globular capillary loops. So my morphological diagnosis is this transplant globulopathy is because of chronic AMR. This is silver stain, and silver stain also highlights. You can see one capillary loop like this, one capillary loop like this, a clear space. Similarly to one here and one here, a clear space. So extensive duplication. PTCs also. This is just to highlight there is PTC capillaritis, and the thickness of the peritubular capillary is very similar to the thickness of the tubular basement. Normally PTC is so thin walled you are hardly able to appreciate. But when you see a thick wall PTC, the thickness of the PTC wall is similar to the tubular basement membrane wall. That means it is a thick PTC. And on ultrastructure examination, you are going to see PTC multi-layering if you do in these cases. So vessels also show intimal sclerosis. So I just immunofluorescence has to be negative, C4D has to be positive, then only you label it as chronic. This is just to highlight the globular capillary. So normal globular mesenchyme is positive for C4D. If you see C4D staining in the globular capillary wall, that also suggests a chronic AMR. I'll not go into EM. And one more thing, you can see food process. These are the food processes. Some in chronic AMR, you can see extensive food process effacement. So presence of extensive food process effacement doesn't mean it is FSCS. It is a primary photocytopathy. You have to look at everything. So I'll just rush through that. BKV nephropathy, you know. So what I want to highlight in BKV nephropathy is there could be a lot of infiltrate in the biopsy. But if BKV is there, SV40 is positive, it is BKV nephropathy only. You have to, as a pathologist, you have, as a clinician also, you have to remember that when you see vascular rejection with BKV, then only there is an associated rejection. If you see tubulitis, interstitial infiltrate, it is not cellular rejection. It is all because of BKV. This is just to highlight the inclusions. And this was, in this case also, the first biopsy somehow SV40 stain was not done, because they said when morphologically inclusions are there, then only we do. SV40 should be done in all biopsies. I do 1 month post transplant, I do SV40 in all biopsies. I think the majority of the time BKV comes after 3 months or 4 months post transplant. But I routinely do post 1 month transplant, I routinely do BKV. C40 has to be done. So the first biopsy was showing very minimal chronicity, you hardly see any greenish area, and the second biopsy showed progression of chronicity. And this is a BKB stain S340 which comes positive. So sometimes I remember this was a case in 2014. I was in Vedanta those days, and this patient, this was like 1 month or 2 months post. 1 month, I think less than a month post transplant. Basic disease, diabetic kidney disease. Many times I know patients will come with CKD. There is a history of diabetes for 20 years, and you will give a diagnosis. Yes, it is diabetic. This case, diabetic, no biopsy done, nothing. So based on clinical thing, diabetic. So there was creeping creatinine 1.7 to 2.4, graft dysfunction. So you see at this magnification, you can see blue cells. So possibly you will think, possibly I am dealing with a rejection kind of a thing. This is a PS stain. So important thing is in PS stain there was some casts which were PS negative. So when I say PS negative or weakly PS positive, so a true TAM phosphor protein cast should be PS positive. It should be dark magenta. If you see weak PS positive cast and there is a reaction around that cast, that means this cast is composed of exogenous material. It is not composed of endogenous material. Okay, because the body is reacting to this exogenous material. And then there are some cracks, there are some fractures in this cast. Kappa lambda was positive, kappa was negative. Then protocol was made, all patients, 50 years or maybe 40 years, you have to do electrophoresis and all that before you take these patients for transplant. That is very important. You have to remember that. It is, and all these patients, they are labeled as diabetic kidney disease. So in a diabetic kidney disease, if you feel there is something unusual, please, before you go ahead with the transplant, because cast nephropathy will come in the first 1 month. There was associated light chain deposition disease also. So he lost his kidney because of multiple myeloma and biopsy was in bone marrow. And this is interesting case. This was a 41-year female, Pakistan national, diagnosed as advanced renal failure in December 2013. Not a known diabetic or hypertensive. No symptoms to suggest systemic disease. Native kidney biopsy in Pakistan labeled as end-stage kidney disease, which actually is a clinical diagnosis, end-stage kidney disease. Started on maintenance hemodialysis in May 2014, renal transplant in December 2014. Baseline creatinine post-transplant was 2.4, which is surely a higher side. Allograft biopsy was done outside, POD5, mild ATN, progressive rise to 3.6, POD 4 months, again repeat biopsy, no evidence of rejection, CNA toxicity because obviously ATN was there. Everolimus was introduced, serum creatinine in December 4.6, nausea, vomiting and all that, no decrease in urine output, and POD 15 months, he came to Artemis Hospital and serum creatinine at that point was 4.8. Urine routine microscopy showed 2 plus proteins, RBC 2 to 3, and I was not aware about this history. I thought this biopsy has come and this is like POD 15 months post-transplant. And I tell my nephrologist, there is a scar-like area. This should not happen in the rejection that one area is completely blue, other area is absolutely fine. In a focal rejection that can happen, but in this case, there were tubules, normal looking tubules which are here, but this area was completely gone. So this was an area of scarring. So it is, this was a subcapsular scar which was there. This is the area of the subcapsular scarring. But in the tubules, so what you can see is, you can see the brush border and there is disruption of the brush border, what I showed you. I said this is ATN. So then my nephrologist informed me that this is the 5th biopsy and you are saying the same old thing, ATN. And this patient's serum creatinine is rising. I said, let's wait for the immunofluorescence. Immunofluorescence was negative. I make a routine, even if it is a 10-year-old kid or 20-year-old kid, I'll do kappa lambda in all biopsies, in all transplant biopsies. Native to I do only, transplant also I do kappa lambda in all biopsies. This was the only pathology. Lambda was positive in the tubular protein absorption droplets and kappa was negative. So this was a case of proximal tubulopathy, post-renal transplant. So this patient had proximal tubulopathy. And initially also the biopsies, whatever were reported, and it present only as ATN. You are not going to see tubular cast, the cast which I have shown you, the cast nephropathy like thing. So this will be picked up only if you do kappa lambda. If you are not doing kappa lambda, you are going to mess up. And then electrophoresis, everything was done, and it showed that bone marrow also showed multiple myeloma. And this is immunohistochemistry we did. Immunohistochemistry, whenever normally kappa is always more than lambda. The moment you see more lambda staining than kappa, consider it as pathological. Except there is one exception to this. Normally, kappa is always more than lambda, but there is one entity in which lambda is more than kappa, and still it is not a monoclonal disease. What? नहीं क्रिसेंटिक तो IgA बोल देते हैं क्रिसेंटिक IgA to next level. Yes, primary idiopathic, primary IgA nephropathy, lambda is always more than kappa. Kappa will be 1 plus, lambda will be 3 plus. Kappa would be negative also, lambda is 3 plus. Now, if you see 3 plus kappa in IgA and lambda negative, you should think of doing some electrophoresis or that. It could be monoclonal IgA, and that happens mostly with elderly. See, we know IgA is a disease of young people. You see in the age group of maybe 20 to 40 or 45. You don't see IgA. IgA can occur in 60-year-old also, but it is not a common disease at 60-year-old. But in a 60-year-old male, if I see IgA and that IgA is showing 3 plus kappa and lambda negative, I will investigate that patient for monoclonal disease. Okay? So exception, absolutely correct. IgA nephropathy. So serum electrophoresis showed and spike. So this is also an interesting case in a way that I'll in this the last case nephrologist helped me arriving at that diagnosis because she told me that see there is something more in this. It can't be only it. So this was a 30-year male resident of Nigeria on maintenance hemodialysis for 2 years, basic disease CGN. Presented in fact 2014 for renal transplant, donor brother, renal transplant March 2014, serology for this is negative. Renal allograft recipient March 2014, ATG induction, standard immunosuppression, lab investigation, serum creatinine 1.3, acute graft dysfunction, accelerated hypertension, POV 6 months, and acute rejection, DKV nephropathy. So this was a biopsy. So what do you think? Whenever you see pale kind of thing in between the tubules, that means it is interstitial edema. I told you, if you see more white color, it is edema. If you see more pink color, it is fibrosis. So here you are seeing more white color. In a transplant biopsy, if you see more whitish kind of appearance in the interstitial area and you see plasma cells, it is a plasma cell rich rejection. Okay. So in this case, majority of the time there are 3 scenarios, clinical scenarios where I see the plasma cell rich rejection. The most common scenario, drug non-compliance. That is the most common scenario. The second common scenario is patient had recurrent infections due to which the immunosuppression was always towards the lower side. Whether that patient has urinary infection or CME disease. So immunosuppression. The third scenario is sometimes patient says that I am getting this tacrolimus or mycophenolate from some dispensary, from CGHS dispensary or something. CGHS people should not be there listening to this, but I am telling you, these are the clinical scenarios. So whenever I look at a biopsy, it shows interstitial edema and you see a lot of plasma cells, think of plasma cell rich rejection. If the background is pink, fibrosis, and you see plasma cells, the differential should be BKB nephropathy and the second differential should be PTL. Okay? So you see all these are plasma cells, eccentrically placed nucleus and then this kind of cytoplasm, and you will say plasma cell in the interstitium, and the plasma cells are also going to infiltrate into the tubules. So plasma cell rejections, they are steroid resistant form of rejection, but sometimes they respond to 5 pulses of steroids, but majority of the time you do everything, you give cortisone, everything you do, but somehow they don't respond. So in this light microscopy, globulus was fine, there was no TMA, there was no significant membrane thickening. C4D was negative because it is there in the globular mesenteric, that is a normal positive control. Yes, this was interesting. There was IgG. IgG should be absolutely black, but IgG was showing a minimal granular staining along the globular capillary. I told my nephrologist that there is something here. I think this pattern is more like membranous. But obviously the chief complaint was rising serum creatinine. There was no protein here at all. So kappa lambda was also showing similar kind of staining, no monoclonal restriction. So we label it as acute cellular rejection, plasma cell rich, BAF type 1A, MGN recurrent no de novo, and my nephrologist said please don't write this MGN, it is just incidental finding. See, important thing is IgA in the globular mesenteric could be incidental finding, but IgG along the globular capillary loop can't be incidental finding. Okay, there has to be some reason for that. And the other thing what I want to highlight is many times on routine microscopy you will see a normal globulus, but immunofluorescence will show deposit. So if there was no significance of immunofluorescence, people would have diagnosed membranous on light microscopy. So immunofluorescence has to be done in all cases. DSA was negative, received 5 doses of methylpred, bortezomib, serum creatinine 5.2, rising. See, now UPCR was 2.19. Repeat biopsy performed just to see whether there was some reduction in the infiltrate or no. The infiltrate was still persistent. It was there. But the IgG became more stronger now. Initially it was 1 plus, now it became 3 plus. I said acute cellular 1A, MCL recurrent D number. Now the proteinuria was UPCA was 2, but then you have to understand there was so severe degree of ATN and all that it could be due to proteinuria also. The first transplant graft loss in November 2014. Second transplant 5 months after first graft loss. ATG induction, everything was done. On POD 13 in the second transplant there was rising serum creatinine to 1.8. Acute rejection. There was some infiltrate and there was some orange color cell. These orange color cells are eosinophils. Normally you get to see eosinophils in a transplant biopsy when there is a vascular rejection or when there is some kind of a small minor component of acute interstitial nephritis, possibly drug related. If this patient is on some antibiotics and all that, you can get to see that. Normal globulus. Immunofluorescence again shows IgG 1+. The second transplant biopsy goes. POD 13 borderline cellular rejection, early MGM recurrent de novo in the second transplant. He responded to 3 doses of methylprednisolone. POD 9 months. Now this patient present with nephrotic range proteinuria. 11.26. IgG 1, 2, 3, 4. Can you tell me if you see more IgG 1 or 4? What does it mean? When you see more IgG 2? Okay, you see IgG4 dominant staining more commonly in the primary membranous, and you see more commonly if you see all the IgG subclasses and no IgG4, that means 1, 2, 3 and no 4, more towards the autoimmune disease, SLE and all that. C40 will be positive whenever you see, whenever the immune deposits are there, C40 takes up the non-specific staining in the immune deposits. So I'll just run through, I've already showed you. So PLA2 was done on the first transplant, it was showing minimal granular staining, then on the second transplant, it was positive. So MGN was there in the first transplant and it presented as nephrotic range proteinuria 9 months after second transplant. So what could have been done in this case? Could you do something different? This patient was taken off for second transplant. What could have been done before that? If a weightage was given that this is membranous, you could have done serum anti-PLA2R level. You could have waited for the levels to settle down before going for the second transplant. So take-home message is histopathological changes can precede clinically evident recurrent disease and surveillance biopsy with immunofluorescence give early diagnosis, and obviously future things are done. So this was my last. So anything, if you have any doubt or something, yes.
Mild infections which can cause ATN, is that also kappa lambda is right?
Kappa lambda should not show any abnormality even in mild infection.
The polyclonal pattern which we see in electrophoresis. So
I am not an electrophoresis person, but yes, I am talking more when I talk about kappa lambda kind of restriction, I talk in kidney biopsy samples. So in infections, pyelonephritis or something, I will not see any change in the kappa lambda pattern of state.
So if there is ATN or the HNE and pass, and then in IF we see kappa lambda, if you see lambda restriction, then we have to think about, right?
Yes, see the thing is, if you see now with paraffin immunofluorescence, so in the last like 5-6 years when I am doing paraffin immunofluorescence, it has changed, it has improved my quality of reporting. Because paraffin immunofluorescence, you are able to pick up lesions which were missed. Like in this case, you are saying there is ATN in the biopsy, but there is electrophoresis which is showing abnormality. So if you want to rule out proximal tuberculopathy, we can always do paraffin immunofluorescence on the block. If there is a demonstrable lambda restriction, that means it is MGRS. Okay. So what is MGRS? How it is different from multiple myeloma? Yes. Example, crescentic IgA. You will answer that. So, if you find a small clone of plasma cells or a very small clone of lymphoid cells, that can only produce a MGRS lesion. Okay. For example, a patient, a known case of diffuse large B cell lymphoma, received R-CHOP therapy. Okay, he responded, and after 6 months, he comes with nephrotic range proteinuria. On biopsy, there is MGM. Okay, it is not MGRS, even if I demonstrate restriction, because there is a big clone of lymphoid cells which has produced a DLBCL in this case. On the other hand, there is a patient who presents with nephrotic range proteinuria. Okay, there is no significant lymphadenopathy, nothing. The only pathology is in a kidney biopsy I am seeing MGM and there is a monoclonal. There is a light chain restriction. That is MGRS. So MGRS has to be the initial presentation. And it is always a very small B cell clone which you are not able to pick up in your routine electrophoresis and all that. So what next step you can do? If electrophoresis is negative, free light chain assays are absolutely normal, what can you do? Though routinely we don't do, you will go for bone marrow examination, it will come as 1 to 2% plasma cells. What next? So you can keep that patient on a follow-up, or the answer, if in exam somebody asks, if somebody has attended these conferences, next generation sequencing. That is a new thing they are saying that you can do, because it can pick up a tiny clone. So you can do flow cytometry of the bone marrow aspirates. You can pick up that. I have been doing paraffin immunofluorescence on the bone marrow biopsies in MGRS cases, and you are able to pick up some 2% plasma cells also if it's demonstrated that lambda is positive or kappa is positive and lambda is absolutely negative. So you can pick up those tiny collections of plasma cells. So you have to remember MGRS has to be a small clone. It can't be a very big clone. Yes, anything else?
Like in chronic and chronic active ADMR,
Yes.
since the chronic activity and MPI, like respiration bronchitis will be there. How do we differentiate the chronic? So only chronic. I'm getting confused with the chronic antibody-mediated rejection and chronic active antibody.
Okay. So the thing is, when you say chronic active antibody mediated rejection, that means there has to be activity. And the activity is in form of microvascular inflammation. If, for example, I am seeing transplant globulopathy, C40 is positive, but I am not seeing any glomerulitis, no PTC capillaritis. I will label it as only chronic AMR and I will say there is no activity in this biopsy. Okay. On the other hand, I see transplant globulopathy, but majority of the globuli are showing glomerulitis and majority of the PTCs are showing PTC capillaritis. I'll say it is a chronic active AMR. So why they have used this terminology, it is said that when there is activity, there are chances that if you treat these patients, there could be some improvement. Anything else? So important take-home message is, please ask your renal pathologist or histopathologist that they should be doing kappa lambda and all biopsies. I see biopsies where in native kidney biopsies also kappa lambda is not done, because considering that this is a 25-year-old male, why he should have a monoclonal disease? So now you see lymphomas, monoclonal diseases at early age group also. So unless you do that, and by paraffin immunofluorescence, when I was telling you, we see cases where it was labeled as FSGS. Okay, immunofluorescence was inadequate, and this patient received all sorts of therapy. And your favorite therapy is rituximab. I think you are competing with medical oncologists now, who will prescribe rituximab more, nephrologists or medical oncologists. So EM is not done, and rituximab is started and then this disease progressed. And when you do paraffin immunofluorescence on the previous biopsy, because previous biopsy immunofluorescence was inadequate, it turns out to be IgA nephropathy with FSGS lesion. So it is very important that if you don't have immunofluorescence, we have a methodology we can do. There are cases in which obese patient, nephrologist will say, I am able to take only one core. So on that one core, we do light microscopy, we do paraffin immunofluorescence, and on the remnant tissue we get electron microscopy. But that doesn't mean it can't be made as a routine that you send me one core. There is an option which is always there. Okay, if there are no more things, then yeah.
So when you mentioned in AMR immunologic criteria that presence of gene transcripts or what are these?
So the thing is, there are gene signatures which are coming up. So what is happening is now BAM, it is becoming more and more complicated. I won't say more complicated, but I'll tell you, related to oncopathology also, there are terminologies which are coming. If you find this molecular signature, this is this tumor. So similarly, they are coming up with molecular signatures based on which they say if this molecular signature is there, it is more like infection. If this molecular signature is there, this is more like rejection. But whether the nephrologist will be comfortable in based on those molecular signatures to treat or not to treat, and these are not validated. They are doing studies. It is going to take another 4-5 years to come up with the criteria that what kind of molecular signature suggests. So the majority of the times, this molecular signature is going to help us in a way. As a pathologist, I know many times you say there is an infection. You see some granulocytic cast. You see lymphocytic tubulitis also. You always say that first treat the infection, and then there could be a component of borderline cell mobilization. So these molecular signatures, I feel that they may help in differentiating rejection versus infection, because many of your transplant patients, whenever we see there is pyelonephritis and all that, you say the cultures are absolutely sterile. In transplant setting, somehow that happens that cultures we see in biopsy granulocytic cast, but your cultures are absolutely sterile. So I think the molecular signature are going to help in will be useful in those kind of settings. But till date, I don't think in the next 5 years those molecular signatures are, at least in India. PLA2R took so much time. So now we are doing PLA2R. Now there is one more thing. EM has a very limited role in membranous because with PLA2R, thrombospondin, semaphorin, L1, exostotin, 2, 3, so many antibodies being there. There is hardly any role of electron microscopy in membranous. But then also, I'm not saying that you should not do EM. Once in a lifetime, a kidney patient will undergo biopsy only once, majority of the time. You are not going to do sequential biopsies. So EM should be done in all native kidney. Yes. Done. Thank you. Second year and final year. So majority of final year. So you know what all stains we use, because my whatever I'm going to discuss, it will be a case-based discussion, and I'll show you cases, and I'm going to highlight importance of doing immunofluorescence in certain cases. And when I will show those cases, then you will understand it better. So before I start this transplant kidney biopsy, so as we know the BAP criteria which are there. Anyone knows when was the first BAP conference conducted? 91. Okay. And where was it conducted? Where is BAP? Okay. So I'm going to show you more images rather than theoretical kind of thing, and I'll try to make it interesting. I may ask you, what do you think? What is there in the slabs, so that you are all of you are awake and you are listening. So this is an 18-year male post-renal transplant. Donor is mother. There is rising creatinine from 152 to 2, and TAC level is 6. Basic disease unknown. Suspicion was rejection. Recent disease. Though they suggested that there was no proteinuria, I don't know why they kept one of the possibility as a recurrent disease and thrombotic microangiopathy. So when you look at this kidney biopsy, what is the first impression you have? Do you think there is infiltration in this biopsy? Do you think there is rejection when you see this image? Okay, what you can see is whenever we look at a kidney biopsy, the approach is very simple. We look at 3 compartments. This applies to native as well as the transplant kidney biopsies. We look at the globular compartment. We look at the tubular interstitial compartment. And these are the tubules, and intervening areas is the interstitial. You hardly see any interstitial because this is how a normal histology should look like. All the tubules are arranged in a back-to-back manner. You hardly see any interstitial. But when there is tubular injury, or when there is interstitial edema, or when there is interstitial inflammation, these tubules will be separated from each other. So you know, okay, there is something in that interstitial which is going on. Even an ATN can produce some amount of interstitial edema if it is a moderate degree of ATN. But if it is a mild ATN, it is not going to produce interstitial edema. It is just the pathology will be seen only in the tubules in form of electron microscopy. What will electron microscopy show if there is a tubular injury? That is the earliest change which happens. It will show a loss of brush border. So tell me one thing, brush border is seen in proximal convoluted tubule, distal convoluted tubule, or collecting tubules? Proximal cannulated. So you will see the 18 changes dominantly in the proximal cannulated tubule in form of loss of fresh water. So in this biopsy, all the tubules are arranged in a back-to-back manner, but we know from the clinical history there is rise in serum creatinine. So you have to understand when a pathologist says he's not able to, so it is like a diagnosis of exclusion, ATN. You have excluded infection, you have seen this glomuli, it is not showing any TMA. There is no glomerulitis, there is no PTC capillaritis, and it is showing C4D is also negative. So, but you have, but as a pathologist, I have to explain what is the reason for rise in serum creatinine. I'll say ATN, and you will also be very happy. And you look at the trough levels, you'll say yes, the trough levels were towards the higher side. So everything is explained and everything is settled out. So majority of the times ATN is actually a diagnosis of exclusion after you have excluded common things which can lead to rise in serum creatinine. But there are certain histopathological changes you are going to see in ATN. Like in this biopsy, at low magnification, someone can say it is a normal histology because glomerulus looks fine, the tubules are back to back, there is no interstitial edema. But when you go to high magnification, so this is first a glomerulus where you can see these glomerular capillary loops. These are the intervening areas. What are they called as? Mesenteric. So mesenteric is like a supporting media of a glomerulus. What do you think this is? And what do you think this is? So okay, this is the glomerular hilum, okay, because it is a dilated vessel like this, and this area will be opposite to this, will be a tubular pore, okay. So not in all glomuli you will be able to visualize all these tubular pores and everything, but we have to see that inside the glomerular capillary loops you are not seeing any cells. That means there is no glomerulitis. So you have to understand there are two things. In a native kidney biopsy, if there are cells in the glomerular capillary loop, we call it as endocapillary proliferation. But in a transplant biopsy, if you see inflammatory cells or lymphocytes within the glomerular capillary loop, you label it as glomerulitis. Okay. And many times when there is a recurrent glomerular disease, so whenever there is a recurring glomerular disease, in our reports we never do glomerular scoring because that glomerulitis, what we are saying, or endocapillary inflammatory cells. For example, there is a recurrent IgA nephropathy, and I am seeing some inflammatory cells in the glomerular capillary loops. So it could be due to IgA nephropathy. So that means it is endocapillary proliferation. But when I use a terminology of glomerulitis, that means in the bottom line, in the final diagnosis, I am going to label it as an antibody-mediated process and not a recurrent GN or a de novo GN. So you have to remember that. So endocapillary proliferation terminology is used in a transplant biopsy when we are sure that it is a recurrent kind of GN or a de novo GN. So in this biopsy, the glomuli looks fine, there is no TMA. Now look at the tubules. So these are the tubules and you can see these nuclei. Just see the arrangement of these nuclei. Normally they should be at regular intervals. So you can see these blue cells are nuclei, and suddenly you hardly see any nuclei. There is a pale nucleus here, no nucleus here. And again, this is the normal arrangement of the tubular nuclei. One here, second here, at regular intervals they are seen. But in this area, you don't see that regular arrangement of these tubular nuclei. On the other hand, just look at this tubule. You can see this nuclei, you can see this nuclei, and see the other aspect of this tubule. You hardly see any nuclei. So all these features suggest that there is an acute tubular injury. And one more thing is there. You can see some roughened kind of stuff here, irregular border. So these irregular borders are actually brush borders. Okay. So whenever you see a roughness of the luminal aspect of the tubule, and you see these kind of things, that is possibly these findings also suggest that there is a tubular injury. And PS stain is a very good stain. PS and silver stain, they are very good stains to demonstrate the glomerular pathology, and they are very good stains to demonstrate the brush border also. So normally PS, whenever we say something, it is PS positive, that means it will have a magenta color. So when I say magenta color, the color of the PS positive thing should be like this. You can see the magenta color here of the Gomez capsule. And similarly, look at the inside aspect. And if you follow this is a brush border. Inside area, this whole thing is a brush border. And suddenly, like in this area, there is some disruption in the brush border which is there. Okay. So these findings suggest that there is a tubular injury, but yes, this tubular injury is very mild. It is not a moderate or severe degree of tubular injury. C4D is also negative. So I have excluded infection. How I have excluded infection? There are no granulocytic casts in the tubules. I have excluded AMR because there is no glomerulitis, there is no PTC capillaris, C4D is also negative, there is no DMA. There is no infiltrate in the interstitium, there is no tubulitis, so I excluded infection. So the final diagnosis is it is ATN. So, like if I say ATN, do you think that any rejection can also produce ATN? Which rejection? Antibody mediated. So antibody mediated rejection, whenever the ATN is there, it will be picked up only on the sequential biopsies, provided you are doing routinely DSA. Every time you do, and you routinely don't do DSA, you are going to do a DSA lysate, which is not a very good thing, and obviously because it turns out to be expensive also. So whenever AMR, when it leads to ATN, the ATN will not be of mild degree. ATN will be of moderate degree. And when you do a repeat biopsy, there will be progression of ATN from moderate to severe. Okay, but when there is no progression of ATN in the sequential biopsy, C4D is persistently negative, it goes more with the CNS. I have seen cases where 4 or 5 biopsies are done because repeated biopsies are showing only ATN. Okay, I don't have that case, but I'll tell you. Yeah, I think I'll be presenting one more case where it was only ATN in 3-4 biopsies which was done, and I'll tell you what happened finally. So it is very important that some patients are not able to tolerate CNIs at all. Even at low doses, you will see the trough levels are absolutely fine, they are towards the low side, but that patient is not able to tolerate. So the moment they are off CNIs, so there are cases where 4-5 biopsies are done, DSA is done, everything is negative, there is only ATN which is there, and the ATN is due to CNIs. Majority of the times, first 2-3 months post-transplant, if you see ATN, majority of the time it is due to CNS. There is one scenario which we see commonly, that patient had a recent episode of diarrhea due to mycophenolate and all that. And what happens because of the routine metabolism of CNIs get altered and patient will develop ATN. But if this kind of a clinical scenario is not there, that means 1 year post-transplant, this patient has slowly rising serum creatinine, I see only ATN, and there is no history of some diarrhea or something because of mycophenolate. C4D is negative, there is no glomerulitis, there is no PTC capillaris, it is only ATN, and that ATN is like mild to moderate degree. It is not a very mild kind of ATN. I remember one case where I said it is possibly because of the CNA toxicity. Then I realized that after reducing the dose of CNA, the serum creatinine, there was further rise, and the repeat biopsy showed C4D positive. So 1 year post-transplant, if there is no setting of ATN, you have to keep possibility of antibody-mediated resistance. If the immunosuppression is absolutely within normal doses and everything is fine. So this was like diffuse acute to plane 3, and after correcting the trough levels, everything went fine. So I'll not go through the details of this. 1991, this was there, 1993 it got published. What I want to highlight is there was criteria of hyperacute rejection. Now we hardly see hyperacute rejection. Can you tell me why? Yeah, so this was a time when we were doing only CDC cross-match. Now you have a fantastic immunopathological workup. You do CDC, you do pen-reactive antibodies, you do flow cytometric cross-match. And do you do DSA routine or only in selected cases? Single antigen DSA. Selected cases. But then also with the CDC and flow cross-match, you are able to. So you hardly see. I have seen in the last 12-13 years, so I see hyperacute rejection only in APO incompatible setting. Okay, otherwise I don't see hyperacute rejection. It is not very common, provided there is something which is missed during the CDC or in the flow cytometry. Only that. Otherwise, you don't get to see them, hyperacute rejections. So there was a category of hyperacute rejection. So any textbook of nephropathology, What? Yes, you are correct. Hapton-Stall. Hapton-Stall is a book, textbook of nephropathology which you follow, and if you look at the previous editions, you will get a chapter of hyperacute rejection. And now there is a small paragraph of hyperacute rejection because you hardly see hyperacute rejection. But yes, in an ABO incompatible setting, when there is a hyperacute rejection, you will say titers are fine, everything is fine. How come this patient is having that? So somehow in ABO compatible setting, the histology doesn't correlate with the titers. Even if the titers are absolutely fine, you are going to see a patient with a TMA, and the next step is you are going to go for graft nephrectomy. Somehow, in the first 2 weeks, and that was the first week, if you see C4D positivity, because accommodation takes some time, it is not going to happen in 2 days. So, first 7 days of AVO compatible setting, if you see C4D positivity, consider it as pathological. Don't consider it as accommodation process. So, what I want to highlight is, and this kind of a rejection, obviously you can also diagnose tubular interstitial rejection because you see blue cells in the interstitium. You see the tubules, look at this magnification, all these are tubules and they are separated from each other because there is interstitial infiltrate, interstitial edema. You can see here, you can see these blue cells, and in histopathology, if you see blue cells, that means they are lymphocyte, and if you see more pink stuff, that means it is fibrosis. Okay, so you see more blue cells here. So blue cells means there is lot of infiltrate which is there, and you can see these blue cells which are the lymphocytes which are infiltrating the tubules also. So there is tubulitis. So there is grading of tubulitis. It is grade 1, T1, T2, T3. So it doesn't change the management whether it is T1, T2, T3, but if it is associated with a vascular rejection, obviously many times your protocol is you will not give 3 pulses, you will give 5 pulses if there is a vascular rejection. So in this case, if it is like less than 4 lymphocyte in a tubule, you label it as T1. If it is 4 to 10, you label it as T2. If it is more than 10, you label it as T3. So based on that, if it is a severe tubulitis, that means T3 tubulitis, and the infiltrate should be more than 25%. Interstitial infiltrate. If interstitial infiltrate is less than 25%, there is mild to moderate tubulitis, you label it as borderline cellular rejection. But if the tubulitis is severe, moderate to severe, and the infiltrate has to be more than 25%, then only it is acute cellular rejection, grade 1A or 1B. 1B is when there is severe tubulitis. So, 28-year male renal transplant, this is the old case, 2013, first biopsy POD4, ACR BAF type 1B. That means 1B means there must be tubulitis which was severe. And second biopsy was done on POD13 because there was some improvement in the serum creatinine, but serum creatinine was stuck. So first biopsy showing infiltrate and second biopsy show no infiltrate. So that means steroid has done their job, the infiltrate is gone, so it is no longer rejection, but the ATN is persistent. And ATN could be due to CNS also, so it settled down on its own. All the trough levels were corrected. And many times you will say the trough levels are towards the higher side, but serum creatinine is rising, it is rejection, but you see infiltrate. So that is why it is always said that when you are thinking that whether I should do biopsy or I should not do biopsy, you should always do biopsy. Because many times we see biopsy where the trough levels are towards the higher side, still there is rejection in the biopsy. So, yes, coming to the vascular rejection, there are two terminologies we use, endotheliitis or sometimes intimal arteritis. Both means the same thing. It is just that how much infiltrate is covering the luminal circumference of the vessel. If less than 25% of the luminal circumference is occupied by inflammation, we label it as B1 lesion. Okay. When more than 25% of the luminal circumference is involved, you label it as a V2 lesion. For example, here you can see this is a vessel, and these are the RBCs. So this is a flattened cell is an endothelial cell. Whenever the flattened endothelial cell is lifted, and beneath that there is a lymphocyte, it is endotheliitis or intimal arteritis. And since this intimal arteritis is seen in less than 25% of the complete luminal circumference, it is V1 lesion. And V1 lesion means it is a type 2 vascular rejection. And when the infiltrate occupies more than 25% of the luminal circumference, it is a V2 lesion. And when this infiltrate is causing necrosis of the vessel wall, or there is a transmural inflammation, that is a V3 lesion. So initially it was thought that when there is a V3 lesion, it is mostly AMR. You see V3 lesions. But even in severe acute cellular rejection, you can see V3 lesions. This is HND stain which shows you can see these lymphocytes which are infiltrating through it is a transmural infiltrate, and there is necrosis also. So this area is complete necrosis of the vessel wall. So what I want to highlight is initially the criteria, the categories in the BAF categories was normal biopsy, hyperacute rejection, tubular interstitial rejection. Then people realized that tubular interstitial rejections are easy to tackle by steroids and all that. The problem they are facing with AMR. So after that, majority of the diagnostic criteria which were laid down, it was dominantly for acute antibody. Now you see the acute antibody T cell mediated rejection will be this much. And when you look at the AMR category, it will be chronic, active, chronic, inactive, acute AMR, and all that. C4D positive, AMR without morphological evidence of rejection. So there are a lot of categories. Then you will see one lesion which is an isolated V lesion. Have you heard of that? Isolated V lesion. So isolated V lesion means isolated vascular rejection. That means in the biopsy, and that happens mostly in the first 2 weeks of transplant. In this biopsy, there will be no infiltrate, there will be no glomerulitis, there will be no TMA, nothing. There will be one vessel, and that vessel will be showing very mild incremental arthritis. Majority of the times, around 70% of the time, they are T cell mediated rejection only. They will respond to 5% of steroids, but sometimes 15 to 20% of these cases show positive class 2 DSAs. Okay, and if they don't respond after 4 pulses or 5 pulses, obviously before you plan for ATG, you are going to do a repeat biopsy. And if you see the progression of vascular rejection from V1 to V3, you know it is possibly a AMR. Okay. So I just want to highlight the antibody mediated rejection. You look at the criteria, and it keeps on increasing. Because people have realized that these are the most difficult rejections, how to treat them and all that stuff. So what do you think this biopsy is showing? This biopsy is showing only ATN, but what I want to highlight is that I have shown you one ATN before, the first case. In this, there are some tubular epithelial cells which are getting dislodged into the lumen. So that means this necrosis is a moderate type of necrosis. It is not that tubular nuclei are like them. They are getting necrosed and they are getting dislodged they are getting sloughed off into the lumen. So that is a finding which suggests that this ATN is not a mild ATN. It is a moderate to severe degree of ATN. So if you find a ATN which is moderate to severe degree, this is just to highlight the same thing. There is necrosis of the tubular. All these are necrotic tubular epithelial cells. When I say necrotic, many times I shouldn't say many times, when you see cortical necrosis, okay, in a biopsy, it is only we say that there is only ghost outline of tubules with complete loss of nuclear details. So in this, there are some tubular nuclei where it is completely necrosed. You don't see blue cell. If there is no bluish color in tubular nuclei, that means it is a necrotic tubular nuclei. Okay, so this was a ATN of moderate degree. This is a pH chain which shows majority of the capillary loops are empty, but there are some capillary loops which are showing fibrin. There are some capillary loops which are showing inflammatory cells. So there is a glomerulitis and there is TMA which is there. In addition to that, normally supporting mesangium is there, which is magenta color, and suddenly the magenta color is gone. So that means there is a mesangial lysis. There is a destruction of the mesangium. All these findings suggest thrombotic microangiopathy, and this is a H&E stain which highlight the same thing. There is congestion of the capillary loops and there are fibrin. There is fibrin. So ATN, microvascular inflammation. When I say microvascular inflammation, it means glomerulitis and peritubular capillaritis. Along with TMA, this is neutrophilic peritubular capillaritis. This is classical. If you see neutrophilic peritubular capillaritis with ATN, you have to raise a possibility. If there is no infection, then there should be no reason why these neutrophilic peritubular capillaritis should be there. Along with that vascular, I am showing you a case where everything was present, but there will be cases where all the things will not be present. There will be one or two morphological findings only which are there. So vascular rejection, C4D positive. So this is the ideal kind of scenario where you get everything, whatever you should see in the AMR. So when you see these findings, it is acute antibody mediated rejection. So C4D can be done by immunofluorescence as well as by immunohistochemistry. If you want to take out only single core, go for immunohistochemistry. If you have taken a separate core, then I'll show you one case where there was no proteinuria and separate core was taken for immunofluorescence, for C4D immunofluorescence, and what I found in that case. So I'll highlight that. So C4D is positive. Whenever you see brown color in the all these are peritubular capillaries, and C4D positivity is seen only in the peritubular capillaries. Sometimes you can also see in glomerular capillaries, but that happens mostly with chronic AMR. So I'll just run through, chronic allograft nephropathy. So when this terminology was moved and IFTAR terminology was utilized, and this. So what do you think this stain is? Left hand side. Yes, this is Mason's trichome stain. So sometimes different labs use different color. So when you use a green color counter stain, the fibrosis will be green in color. When you use blue color counter stain, it will be blue in color. And this is a pH stain which highlights all these What do you think these areas are? These dark looking areas. So these dark looking areas are actually atrophic tubules. So what I want to highlight is this is ICTA. There is interstitial fibrosis and there is tubular atrophy. So you should be knowing that if C4D is negative, there should be only no staining at all. But there are certain changes in these criteria. So in immunofluorescence, if C4D is less than 10%, PTCs are showing staining in immunofluorescence. It is the significance by immunohistochemistry. When C4D first came, this article came, it was unknown. But now it is said that if in immunohistochemistry, even a single PTC is positive, you have to consider it as positive. But in immunofluorescence, if less than 10% PTC shows staining, consider it as negative. It has to be more than 10%. C4D staining in the peritubular capillaries to be labeled as positive. And diffuse is diffuse, that means more than 50%. So this is how a normal C4D will look like. So you know your C4D is working because it is staining only the globular mesentery. But it is negative because it is not staining the peritubular capillaries. The background is absolutely blank. This is how a positive C4D will look like. Sometimes you can see C4D staining only less than 10% of the PTCs. This is considered as negative by the MAM criteria. But in immunohistochemistry, even a single PTC, if it is positive, it is pathologic. So there is a diagnostic triad for chronic antibody-mediated rejection, transplant globulopathy. So tell me one thing, when you use this terminology, transplant globulopathy, what does it mean? I've already written, but then also. When somebody says the diagnosis as transplant globulopathy, what do you think? It is chronic AMR? Chronic AMR?
It could be chronic or chronic active. Both can be.
Okay, it could be chronic or chronic active. So, important thing is, this terminology transplant globulopathy, it only means it is a morphological term. That means you are seeing duplication of the globular capillary. Now, why that duplication is occurring? There are 3-4 differentials you have to consider. Whenever we say transplant globulopathy, the first differential is chronic antibody-mediated rejection. It doesn't say chronic active or inactive, it just says chronic antibody-mediated. Because when I say active, that means there has to be microvascular inflammation, glomerulitis, PTC capillaritis. So, chronic antibody-mediated rejection. Now, tell me one thing, you must be reading about duplication of the globular capillary wall. In a native kidney biopsy, in which pathology do you see duplication of the globular capillary wall? MPGN, absolutely. So when I say transplant globulopathy in the transplant biopsy report, that means your differentials are chronic AMR, MPGN. What is the third differential? Chronic TMA. Chronic TMA will also show duplication. So that chronic TMA may be due to it may be due to chronic CNI toxicity or it may be due to chronic hypertension. Because 5 years post transplant, if the globulus is showing duplication. So these are the 3 differentials I'll consider. The 4th differential will be HUS-TTP. But HUS-TTP also it is TMA. Okay, so these are the 3 differentials will be chronic AMR, chronic TMA due to chronic CNI toxicity or chronic hypertension, uncontrolled hypertension, and the third will be MPGN. So how will I exclude all of these? Can somebody tell me? If I want to rule out, yes, this transplant globulopathy is because of chronic AMR. So what all things I have to do? And what all things I need to look for? I need to look for microvascular inflammation, whether there is glomerulitis, peritubular capillaritis. I need to be sure that immunofluorescence is completely negative, because then I will exclude MPGN. Okay, I need to look at C4D, whether it is negative or positive. If C4D is positive, there is glomerulitis, peritubular capillaritis. I'll say this transplant globulopathy is because of chronic AMR. When C4D is immunofluorescence is negative, C4D is negative, there is no glomerulitis, there is no PTC capillaritis, there is some vessels which are showing eccentric hyalinosis. I will say this is possibly a chronic TMA due to chronic hypertension or chronic CNI toxicity. Okay. So transplant globulopathy is not synonymous with chronic AMR. Transplant globulopathy just say that they are glomerular with duplication of the glomerular capillary. So that suggests it is a chronic process which is going on. So what you are going to see, some duplication of the capillary. I will show you more of these. So then there is IFTA, a So in all the compartments you are going to see chronic changes. That means in the globulus you are going to see duplication, that is transparent globulopathy. In the tubular interstitial compartment you are going to see IFTA, that also suggests chronicity, and in the vessels you are going to see some internal fibrosis. In other words, that is called as transparent tachydopathy. Okay, so all the three compartments are going to show chronic changes. In electron microscopy, whatever duplication you are seeing, you are going to see a GBM. One more important thing, whenever you are not going to write pathology reports, but the thing is, whenever